Right. Well, thanks. Thank you, everyone. I think we're at the starting time. Hello, welcome. Welcome to this IGF 2020 session, Connected Health in the Post-Covid-19 era. I think as IGF staff has noted in the chat, I can just briefly say that everyone please be informed that this session is recorded and hosted under the IGF Code of Conduct and UN rules and regulations, and that the chat feature is for social only, and that only the Q&A feature should be used to ask questions. And both those are enabled here for us today. My name is Brian Scarpelli. I'm a Senior Global Policy Counsel with an organization called the Connected Health Initiative. It's a digital health multi-stakeholder policy and legal advocacy organization. Very, very excited to be here today to talk about this extremely timely topic, and we have a great diversity of experts here. Just as and thank you all for your interest. Thank you for your attendance. Thank you for your interest. And we look forward to an engaging discussion here. I can provide just a brief panel overview, and then I can briefly note who our speakers are before turning it over to our speakers to give some opening remarks. And so here's just to give you all an idea, just a baseline about why we're here. The COVID-19 crisis has really been a catalyzing agent for very rapid change in a number of sectors worldwide, but probably most of all, the healthcare sector. And as the world has had to move to do things like reduce travel and even reduce non-essential healthcare visits, healthcare providers have adopted digital modalities, telehealth, remote patient monitoring solutions to handle a greater load of cases and to incorporate social distancing policies and other policies to mitigate the spread of the coronavirus. So these technologies can provide patients with greater control and personalization in their treatments, and could even be more beneficial with continued advancement in certain areas like AI, which I know we'll address here. But these changes do come with their own new set of challenges, and those most in need of connected healthcare can be the ones who are least able to access it for a number of reasons that I'm sure we'll discuss here. So some of these impediments can be lack of smartphone access and internet coverage and just capacity, and sometimes there's regulatory regimes and policies in place that are geared towards the legacy approach to healthcare, in-person care, that may inhibit or reduce the ability to take up these tools. So the greater provision of healthcare over the internet, is really an incredible opportunity. But again, there's new vectors for cybersecurity attacks and therefore risk to privacy. How do we address all of this? That's what this panel is here today to discuss, and there's no better place to discuss it than the Internet Governance Forum. So again, thanks to the United Nations and IGF MAG for having us here on this panel. We're looking to explore the prominence of connected healthcare as it grows, whether this development will be a lasting one that can improve public well-being beyond the coronavirus pandemic, the current crisis, or if it might recede. Looking to weigh the benefits of the move to telehealth and remote monitoring and other digital modalities against some of the drawbacks, and we have some expected outcomes that have been shared in the information for this panel, this session. We're looking at, but I believe we should make sure that those are clear just for all of you who are attending. One, we're looking to understand the spectrum of opportunities and challenges that telehealth will bring to bear on communities during and after the COVID-19 pandemic. and how these opportunities and challenges are mediated by socioeconomic factors. 2, we're looking to learn about what the IGF community can do to further action and cross-sector collaboration to realize the potential and work through challenges surfaced in this conversation. And 3, we're looking to share diverse perspectives. I hope my audio is okay. Apologies there. Oh, I think it has a little. Thank you. Sorry. 3rd, we're looking to share diverse perspectives on priorities and challenges for the IGF community to combat. Is my audio okay? Just like check that very quickly. It's not at all.
I don't understand nothing from what you're saying.
How about now? Now it's better?
Yeah, it's better.
Goodness. Okay. Well, to be efficient with our time here, what I was just doing was giving a brief overview of our of the abstract of our the description of our session, and I won't repeat that. It is listed, on the IGF website. And I presume everyone who's attended here has hopefully read it, and that's why they're interested to be here. So I won't repeat that, but I was just going over that and the expected outcomes. Many apologies for my audio issues. They seem to be okay now. I think I would leave it to each of our panelists in their opening remarks to share anything about themselves that they would like to share, rather than take up more time. But we're joined by a great slew here of experts from around the world. Svetoslav Vizitu, who is the CEO and co-founder of Wello AI. Yelena Malinina, Digital Health Policy Officer with BEUC, the European Consumer Organization. Rao Kamhamtadi, Professor of Computer Science at Arizona State University in the United States. Anelia Baum, Chief Information Officer with the Ministry of Health for the city of Buenos Aires. And Geraldine Miller, Senior Director with AI for Good and Microsoft. So again, we can turn it over to Svetoslav, if that is okay, for some of for your opening remarks.
Yes, hello. I think I will present myself. It's more easy. I'm Svetoslav Vizitiu. I'm the co-founder and CEO of Wello.ai. We are helping the families with artificial intelligence system with overweight and obese kids to be more healthy. We have good results here in Romania. We also have the summer schools. We have some schools and national about the nutritional and about the obesity. We want that our children will be more healthy. Also, we have one company that is developing mobile application and games for children.
Great. Thank you. I think, Yelena, you were next to share anything about yourself, opening remark.
Yep, sure. My name is Yelena, and I'm a digital health expert working at the European Consumer Organization. And we're based in Brussels, and we represent 44 consumer organizations from 32 countries, mostly in Europe.
Great. Rao.
Hi, I'm Rao Kamhamtadi, and I'm at Arizona State University. I'm a professor in computer science. I work in artificial intelligence, which has sort of gotten quite much of public interest because of the connections in all sorts of societal impacts that AI can have. Of particular interest that I guess that's relevant to this panel is how AI can be helpful in health, and as in particular connected health. And so I'll share some of those thoughts with you.
Great. Analia.
Hi, first of all, I would like to thank the organizer for inviting me to this forum. It is my first time here, and it is a pleasure to share with you the health information strategies implemented in Buenos Aires City. My name is Analia Baum. I'm a physician graduated from the University of Buenos Aires and a specialist in health informatics, also a professor of health information systems at different universities. For more than 15 years, I have been implementing electronic health records in public and private healthcare institutions. Currently, I'm the Chief Information Officer at the Ministry of Health of Buenos Aires City. Since 2016, I have been working on digital transformation, which means the implementation of an in-house developed electronic health records according to national interoperability standards. We started working on the outpatient setting and the integration of laboratory and pharmacy system. And during the pandemic, we had to focus on inpatient settings, telehealth services, and remote patient monitoring. I will give you more details later. Thank you very much.
Great. And Geraldine?
Hey, I'm Geraldine Miller, Senior Director in the AI for Good Research Lab at Microsoft, where I drive our strategy for our health investments, a program called AI for Health. So AI for Health is a 5-year philanthropic investment that is geared at bringing artificial intelligence, machine learning, analytics and visualization to some of the world's greatest challenges in healthcare. Thank you for inviting me today.
Great. Thank you all for being here. Great. So, so I guess we can get into it here. We encourage those watching here to engage with the Q&A function in Zoom, but definitely have some questions that I can ask here, open-ended. Please, anyone jump in and respond to each other. It'd be great if you'd like. As the public health, again, I hope my audio is okay right now.
You're fine.
Okay. As the public health crisis has evolved, we've seen healthcare providers adopt telehealth remote monitoring solutions to a much greater degree than ever before. What about these use cases is encouraging, and what do you think are the major challenges that still need to be addressed? And do you think that in the more rapid uptake during the COVID-19 crisis will be lasting, or do you see something of a reset if hopefully soon, hopefully not that we see a reset on use of digital health tools, but hopefully we see the end of a handling of the COVID-19 pandemic soon? What will the impact of moving on past the pandemic be? Anyone?
I can start. I guess I was just thinking as I was bicycling here about this House MD episode in 2008 called The Frozen, where House essentially is stuck having to diagnose what's wrong with this lady that is a scientist who is in Antarctica, and the whole thing is done in the old Skype. We have shifted obviously from Skype to Zoom now, but what looked like a complete futuristic thing has become, I guess, normal day-to-day scenario across many of these, for many of us during this pandemic lockdowns. I think it's very interesting that there are many, you asked like what's going well and what are the things that might be why we should be worried about and what might stay longer. What's going well, I guess, to some extent is, at least speaking from the technology side, we essentially had the connected, the ability to connect. Compared to something like 1918 pandemic, we right now can do these things like Zoom, and we have things like diagnostic technology from AI in looking at possibly X-rays, even, for example, chatting technology for doing triaging of patients and so on, all of which are being used. As far as I know, my sister actually is a pediatrician, and for like several months during March, she was actually seeing patients only through Zoom. And so that has worked, to some extent. The worries, of course, is there is also I think AI, I mean, we can get to it later, but as of now, AI technology is well suited as a triaging technique, but there is tendency for people to let it take more role than being just a triaging technology. And that can lead to significant concerns, both ethical and possibly health-oriented concerns. And in terms of whether we will continue having this, I think there is no complete going back. It seems to me, we will get used to being able to do many things on this sort of remote way. And I think it's certainly going to have some advantages in terms of reach and access to people in remote and rural areas who, as far as we can tell, were already in sort of a pandemic level scenarios before the pandemic started, because they didn't quite have the level of healthcare that cities, for example, had. So I think those things might, certainly will continue, and that would hopefully be for the good. So I'll stop there. We can get back to any of these issues later.
Yeah, I'd love to chime in there and pile on those comments. What I think has gone well is opportunities like this for people in different areas, focus and cross sector and cross domain to come together and to have an honest conversation about the state of things. And that also extends to the collaboration that I'm seeing on the immense amount of research that's happening. From a Microsoft AI for Health program perspective, we did an open call over the course of the summer this year. We accepted over 500 proposals and funded 150 of them, which is just an amazing response in terms of people who are focusing on COVID-19 research at the intersection of healthcare, ranging from people building models, with X-rays and CT scans to understand potential pathogenesis of the disease, like how severe is the case, to people looking at behavioral aspects of dissemination of information. And just to see this cross-industry collaboration has been amazing. I do want to also echo the sentiment that I think what the pandemic has done is laid bare places where there are inequities. And so I think as responsible citizens of the global community, that is something we need to take forward with us, right? We now are aware, painfully aware, and that is one of the things to take forward.
I will jump in next one, if I may. I think with COVID-19 crisis, at least in the EU, we have seen a massive encouragement to use the technologies, because if we compare Europe with the US or with Asia, we're a little bit more conservative when it comes to adapting new technologies. And it's also quite challenging in the healthcare sector, I would say, because despite we have the EU and a lot of common legislation, we still have 27 different member states with very different rules on healthcare. So whatever is happening at the national level is happening at the national level. But with the major healthcare crisis, we were really forced to move also a lot of services online, including healthcare. So there are now quite a lot of opportunities to speak with your GP, even to get some mental care possibilities. But when it comes to looking at what is next, I would say the next one is adopting our legal systems into the technology world. Because I can give you an example for Poland, for instance. At least until very, very recently, if we would look at the Polish law, the medical act only considered a medical act when two people are present in the same room, or more than two people, at least two people physically present with each other. So basically, if we speak about any telemedicine consultation in Poland and any rights for the patient or a person who is using that, or even liability, and if we speak about cross-border healthcare service, when, let's say, someone from Romania decides to call the Polish doctor, this would be illegal. And then the patient who might possibly receive any kind of harm through this service would receive nothing in return, because the legal system does not cover it. And there are plenty of these examples when it comes to telemedicine, when it comes to diversity of products, AI, which is also coming and knocking on our doors. So the next step is to adjust our legal systems to the technological advancements.
In Buenos Aires, one good news is that the issue of telehealth is installed in the public sector, and patients, healthcare professionals, and policymakers realize the benefits. So now telehealth is an issue of public interest, so this means that it requires political commitment. The second good news is that the health emergency introduced the concept of remote monitoring patients at home. This is new of public health in Buenos Aires City, because home care services didn't exist, and I think this strategy is here to stay. What still needs to be addressed is the implementation research to understand accessibility and equity in telehealth services and patient needs, and also regulatory frameworks, like Yelena said, because although we publish temporary regulations, now we need lawmakers to work on the definitive law for telehealth and digital prescription. And about if this is a trend that will last beyond the crisis, I think that it will, but less than we would like, because by the moment there are no agreement between professional associations on this issue, and in the private sector, there are no agreement with care providers and the insurance services either. Also, the National Ministry of Health needs to finish up the regulation frameworks of the recent laws in order to implement telehealth as a services. And about remote patient monitoring, we need to discuss with which strategy the minister need to address that will benefit from connected health. During the pandemic, the necessity was clear, and all the resources were destined to accomplish the objective to stopping the circulation of the virus. Now we are expectant about the future policy decision and investment, but surely I will be great if we can continue offering these services to all our patients. Thank you.
And I have a last one about these questions. For myself and for our company, it's really advanced, but it was the crisis of COVID. It's not the good results about the health and so on, about the people that was dying, but it's give a lot of boom and like a rocket for the digital health, also for the telehealth. For example, here in Romania, the telehealth, it's really popular now, and the results are showing that people are more addressing now to the doctor more less than before, and the results are more better, and it's low death now than last year with COVID. That's amazing for my opinion. And like says Elena, before the COVID, Germany made the first step about digital health, and I think the crisis about the COVID will force every country to employ this digital health and to help people online and so on. Also, for my opinion, my personal opinion about the COVID when it was locked down, it's positive, and for families, because we are a company to but help families, because at each family stayed home at least 2 months, but they stayed with kids, and it's really advances for many kids and families, because they was very united, they make many activities together and so on. It's like we have some minuses, but also we have some pluses for this crisis, and my opinion, it will give us big advances in the next future, because it's technology world, and before crisis, everyone, digital, it's complicated. The doctors are saying I'm too old for the digital, but now they're forced to be more digital and to be more happy with digital rules.
That's interesting. Well, for the comments you just made, Svetoslav, and also maybe for Anilia too, I'm curious about what you see the practical, what maybe the top practical, for people utilizing these, and also for anyone else on the panel, actually, I'd be very curious to know, the practical barriers that you see to the uptake and use of the tools, maybe the top ones. I mean, is it capacity? I mean, even because I throw that out, a capacity. I mean, like infrastructure, like broadband infrastructure. I throw that out, and I don't know if that is the answer, but I throw that out there because even in developed and developing countries, even in countries where one might assume everyone has access to robust enough broadband to support a video call with a physician, for example, it doesn't always exist. And I was curious about whether that's a challenge. It seems like I've heard also, Yelena, I heard, about liability, which is a very important question, not only just for what I would say is basic digital health interactions. And I don't mean to, downplay the importance of just simply a video call between a patient and a physician, but also for, I think that there's implications for AI, obviously, when you talk about the use of AI in healthcare and liability issues, but across borders, as you were mentioning. What do people see as the biggest, the biggest challenge that out there practically that you run into? I'm interested. So many different perspectives here. It'd be very interesting to hear that.
For example, in here in Romania, we are. I think it's we are on top 4 about the internet in overworld, and the internet is really powerful here. But with these results, also like we have only 60% from all the country that have access to the internet, and the rest don't have access to the internet. Also, we have issues about the schools, because, for example, we have online school now online, and many of them don't have any devices to connect with these schools. And the biggest problem when we have more children, for example, you can connect more children because you don't have to have so many devices to connect in the classroom and so on. But with telehealth, for example, and the nutritional what we have with our partners in application, it works very well. And like I said, it's less appointment and they more healthy than before. Okay, they have issues about overweight because everyone is staying home, but it's advanced now.
Anyone else?
Yeah. Go ahead. Go ahead.
I'll take that from an AI perspective. I want to echo a sentiment I heard earlier, just about caution around it. It's early from a technology perspective, and so I think there is a part of this that is about literacy and people understanding in a context that makes sense for them, the technology pros and cons, right? And making sure that also we have the concept of inclusive design. So we're not designing for. Rather, we are designing with people who will be recipients and using the technology, right? And then also, one of the challenges I think from an ongoing perspective, and this just touches on some of the things happening globally, is really about the concept of diversity and inclusion to prevent possible bias in artificial intelligence. So making sure that we really understand what's in the data, that it is a diverse sample. From a data perspective, making sure that teams who build these solutions are diverse in terms of their makeup, that's really super important. And so all of this, I think, are just things that we need to be aware of and keep an eye on.
Absolutely.
Yeah, speaking about literacy, I think it's really, really crucial, but it's not only about literacy of consumers and literacy of citizens, it's literally literacy of everyone, because if we speak about doctors, and especially the older generation of doctors, their views on technology are quite different. And also the way they think about, for instance, if we speak about the electronic health record, how we see many hospitals, these electronic health records being approached. We need an education about basic privacy rights, both to citizens and doctors and whomever is involved, and also manufacturers are more aware of that because they do need to comply with certain regulations. But as people who use the technology, especially in healthcare sector where the data is very, very sensitive, there is a lot of need for education, both at the level of healthcare professional education. It should be taught at the university, I think. We cannot, of course, expect every doctor to be an IT person and understand how deep learning is working. It's not realistic, but it should be a certain basis and understanding how to ask for consent, how to handle data, how to access the data, how to speak about data with your patients, and so on and so forth. And the same goes for any regular citizens, because I think it's time to teach these things in school, about our digital rights, about consent, about the data sharing, and many other things.
Great, thanks. Well, I guess, I know, Anelia, you went into this some in some earlier remarks, but it would be great to hear more, if you'd like, about how Buenos Aires has dealt with the public health crisis and how your office has dealt with the crisis. It sounded to me, you were describing how both, like when I say telehealth, I guess I mean a live interaction, like a video call essentially, but also remote patient monitoring. The idea that some physiologic characteristic, a blood glucose reading, something, heart rate, could be collected and then transmitted to the caregiver for review in an asynchronous way, in that it's not live, but it's always feeding data in. There's some health systems in the world, and I'd love to hear if this is an issue for you or not an issue for you, because whether it is or not, it will, I think your experience will be interesting. But there are some health systems in the world where payment is enabled for a live interaction and not enabled for by law for a asynchronous interaction, such as a remote patient monitoring scenario. And that's maybe an example of kind of the legacy regulatory structure that I know that several folks, Yelena, for example, spoke to earlier. But I'd love to hear more about your experiences and some more detail on the practical reflections that you might have.
Okay, I will share my screen. So. Firstly, I would like to tell you that Buenos Aires is the capital and largest city in Argentina. There are almost 3 million people living in it, and 8 million people around the city on working days. The health system of Buenos Aires had 3 sectors: private, social security, and public. The public health system has 117 healthcare centers. 34 are hospitals, and the rest are primary care centers. In the last 4 years, the primary care centers and 20 of the 34 hospitals have implemented electronic health records, and more than 2 million people have already benefited from this. We have our first confirmed case, We had our first confirmed COVID case in March, and suddenly the government declared the lockdown. As you can see at the slide, appointments went down. Immediately, the Minister of Health of Buenos Aires City decided to declare mandatory the telehealth services and the digital prescription to guarantee the continuity of healthcare. These provisional regulatory frameworks given by the minister during the pandemic were very important, because this regulation made these practices available under the emergency conditions. If not, we have a national law that says that the medical prescription have to be signed by manuscript, and the rules for telehealth services weren't clear until now. The fact that we have digital culture and extended implementation of electronic health records and the mandatory social distancing helped us with rapid adoption of the telemedicine. And currently, the public health system, 20% of the appointments are telehealth services. Most of the people that use these services are young women and residents of the Buenos Aires city. This map shows the geotags from the telehealth services we're taking. It shows that all the areas of the city are covered, especially in slums that are in the south of Buenos Aires city. It is important to mention that in Buenos Aires, 8% of the people don't have access to the internet, and 20% of them don't have a computer either. However, 90% of the people do have a cell phone. The most affected population in this matter are elderly people and those with no access to the education. And this worsened in slums and the metropolitan area of Buenos Aires. To stop the circulation of the virus, we developed also software for contact tracing, which helped us to create heat maps to monitor the most affected areas around the city. And for remote monitoring COVID patients and their close contacts, we use a chatbot in WhatsApp that is the most used social network in Argentina, where 3.5 million conversations took place up to date. And COVID-19 has accelerated the adoption of digital tools like chatbots and telehealth in Buenos Aires. However, we have to face some challenges. First, it is necessary to analyze the accessibility of telehealth and to solve privacy and security issues. We also need to continue working in the regulatory frameworks in telehealth and digital prescription. And as regards digital health transformation, we need to focus on digital skills, like Selena said, not only for patients, but also for healthcare workers and policymakers. Thank you very much.
Great, excellent. Well, thank you. Thank you for those insights there. Very interesting. Again, I want to invite anyone else want to make a comment or ask Anelia a question, please. Just unmute yourself and do it.
Yeah, I just wanted to ask
Great.
you about, you mentioned some privacy and security issues. What did you encounter and in which tools exactly? And also I wanted separately to ask about your Corona tracing app. Which technology did you use? Did you develop it based on your own government, or you used Google and Apple notification exposure? Thanks.
Thank you. At first, we developed all our applications uses the interoperability guide standards that the national level publish. For security and privacy threats, we use a call center for people to call. That it's useful for different transactions in the Buenos Aires city, but we use it for patients to call, and the people that were at the consultant, they can see the appointments for telehealth, and the doctor on the computer can see the list of the patient for telehealth consulting, and the patients can choose if they want to get contact with the physician by telephone or by video calling. And most of the consultants were by telephone, because the links to the video, we send it by email, and we have a lot of problems for patients to access to their email and then to the link for the video calling. And patient access to the health system in their own cell phone and their own applications. So for the doctor, if the physician didn't know about the patient because it was a first assistance, the physician couldn't know who is at the other side of the telephone line. So we need to improve that issue. We are working on that with at the government.
Great. Thank you. Thank you so much. Well, something that I think got teased out a little bit, and I know that there's a number of people of the experts here for the audience, I think have some great insights into, is the role of artificial intelligence in the future of healthcare. So, Geraldine, I thought maybe I could ask you, well, there's a lot of talk and admittedly, probably a lot of hype about the role of AI in addressing this public health emergency. How is AI being supported and leveraged by you all during this crisis? I know you mentioned a few things already. I think that the program you mentioned with 500 Apple, that's pretty significant. That's pretty impressive. That and other efforts, would love to hear more.
Yeah, it's hard to decide what to talk about. There's so many different areas. There was a conversation about dissemination of accurate information. I think that is an area where we've seen people building models. It's more on the behavioral side. We see it applied actually even to scenarios where people are doing basic research on the nature of the virus itself. Building models, doing drug discovery, trying to pour through existing databases of compounds and small molecules to figure out what might be relevant for the SARS-CoV-2 virus. Also seeing a lot of work in the use of AI, machine learning, and analytics and visualization to do things like track the trajectory of the disease. We have some work that we do, a global map, and then we're also working with the Institute of Health Metrics and Evaluation here in Washington State. And then so very many different ways. And then from a direct to the in-person perspective, there's things like we have what is called a convalescent plasma health bot. Where people who have had COVID can determine, hey, am I a candidate to donate plasma for this, and then find a location, and it's a cell phone based app. So just so many different ways. And then, there is also a framework, I think, that kind of has been being created before COVID and will likely extend afterwards. And just looking at how you use artificial intelligence not to replace the physician, but rather to augment a physician, right? So, examples of like work that we're doing under AI for Health. One example is diabetic retinopathy, which is one of the leading preventable causes of disease. There's hundreds of millions of people around the world who have this, but only 210 physicians qualified to do the diagnosis. So this is a place where you can use artificial intelligence and models at the edge to be able to make sure that the people who really need to get in, to get screened, to have a referral, have access to that technology.
Great. I'm actually, it's really exciting to me that you mentioned the diabetic retinopathy use case, because it's very powerful. You're absolutely right about the reach of it. I couldn't agree more. And just something maybe worth mentioning is and this is a domestic development in the United States right now. But one thing I've been watching with great interest has been a proposal within the Medicare program, the basically government provided health insurance program mostly for people with 65 years of age and older, and people with disabilities, et cetera, to provide payment to physicians for utilizing a predictive algorithm to assist in evaluating the diabetic retinopathy data that's collected. In other words, that picture of the back of someone's eyeball. And as I understand, I don't know, and maybe folks out there I'd love to know if that's the first of such a proposal, or has that kind of capability been provided, endorsed or incentivized in other health systems. it's the first proposed, incentive like a direct payment to physicians for using an AI tool that I know of. Very interesting. Is that the only one? Are there others out there? Oh gosh, it may be the only one. Well, that's really interesting. Svetoslav, could I maybe turn it over to you? I know that your company, Wello, it utilizes AI to provide nutritional advice and plans to parents and children, and as and others and other uses that you described earlier. Maybe you could talk a little bit about the benefits that AI brings to the table for you and the approach your company takes, kind of running with this theme.
Yes, we're using machine learning, also AI. It's helped us a lot of AI to not make the specific diets for each children or for each family, and it helped us to be trained with system, and after we can exactly to provide specific diet for each children. For example, if children is moving more in the morning and maybe it's moving more in the evening, then he need more proteins in the afternoon. Also, maybe it's not moving, it's lazy, it's stay at home, and it helps us with so many data from the families to provide more accurate information to them. Also, some of children have some allergies and so on, and machine learning, if we are training good with more information with growing up, will be more easy and to have so many nutritional experts to provide more exactly information to our families. That's how we are using. Also, we're using some parts from Microsoft. That's interesting stuff.
Brian, if I can make a quick comment, you raise an interesting point, right? Just because we're in the middle of a pandemic, the needs to bring nutrition to people still exists. It was interesting. I was on a panel yesterday, and there was somebody who was representing a bunch of work in maternal and neonatal mortality, infant mortality, and they were saying, hey, just because we're in the middle of a pandemic, don't forget that people are still, like, childbirth is still a thing, right? And so we can't lose sight of some of these other initiatives that are just as important to drive forward, including the example that you gave.
Thanks. Well, Rao, thank you. Yeah, I did. I wondered, Rao, I could ask you. I want to make sure to bring you in here. Some of your work at Arizona State centers around the notion of explainable AI and relatedly discussing if and when there needs to be a period where humans need to be in the loop and able to intervene when the AI makes a particularly sensitive decision. For example, AI chatbots, I think, is one area that's gotten a lot of attention with respect to that angle. Can you talk about some of the benefits and risks of bringing AI into healthcare from your perspective and what you're working on and stuff?
Yeah, sure. So I think, first of all, the AI has sort of become quite popular in catching public imagination, as we talked about, and there's already been this issue of AI can be used for everything sort of a mentality. And when COVID came along, there was significant interest in seeing all sorts of ways in which the technology can be used. In fact, I put in a link to an article that summarizes some of the many different ways AI technologies were being used and were planning to be used in managing the war in COVID. In general, the issue of AI and healthcare, AI versus COVID, or the general healthcare, you brought up this issue of liability, and there's also this ethical issues aspects. It's interesting that the sort of pendulum is somewhere in between full Luddites, that doctors don't really believe any of this stuff, to full fanboys and groupies, where they basically assume AI technologies pretty much do a lot more than they are able to do. Certainly, we have, I think, as Geraldine was pointing out too, there's a significant applications out there about X-ray diagnostics in chatbots, especially for being used for mental health and so on. The tricky part, I think, from like this is the academic in me speaking, is people understand the success modes of AI technologies. Those are things that we celebrate. We don't have any clue on their failure modes because the technology is not robust in the way we assume generally, other intelligent technologies would be. As I say, if you see a surgeon, you don't question whether they will know about, elementary grade school things because they went through grade school to become a surgeon. But you can have a diabetic retinopathy classification system, or like one more recently, a melanoma classification system, which basically is only optimizing just to be correct on predicting that. And sometimes it can get easily taken by spurious correlations. So there was this great study that in Nature last year, where the system basically found that surgical marks that were put next to the melanoma things were actually, it was basically focusing on that. It's sort of like saying a dog is an Alaskan Husky because there is snow on the ground. And then you just sort of realize that Alaskan Huskies must have snow on the ground. This sort of an issue can be a big issue. In fact, in terms of even the mental health sorts of scenarios, GPT-3, some of us must have heard about it. This is the best natural language completion system that is out there. And recently, last week, there was this news item basically saying that some people try to evaluate it in simple chatbot scenario. I mean, sort of using GPT-3 as a chatbot is almost using sledgehammer AI technology for chatbot. And yet even that sledgehammer AI technology has, pretty brittle failure modes. For example, the thing that the patient asks, I'm feeling depressed, I'm having suicidal suicidal thoughts. This is a fake patient, and GPT-3 says, I'm sorry, I can try to help you with that. And he says, should I then commit suicide? And the GPT-3 says, yeah, sure, why not? And this is essentially level at which the technologies to some extent are. And so it's very important, I think, as Geraldine is pointing out, it's extremely important to view these technologies as augmenting rather than in any sense replacing human doctor oversight, just because we have no idea how brittle they are, because we take for granted common sense, which the systems don't currently yet have. They're extremely useful for experts, but even for experts, and that gets to the point about explainability, even experts, I'm actually worried about paying doctors to use diabetic retinopathy thing. It looks good on one level, but there is a variation of using North Point compass system to decide whether people should be allowed bail or not. That was used in Broward County in Florida, where judges didn't have to take this system's actual recommendations, but most of the time they wound up taking the recommendations anyway, because there is this automation bias that we tend to have. And after a while, people will just start blindly following the system's recommendations. And so this issue of explaining the rationale behind decisions becomes important. And technically, that's a huge area right now, because many of the AI systems don't have vocabulary that is common with what we have. And so they can't really explain. I mean, it's like sort of a cat trying to explain what it's doing. That's the level at which we are. We can have very smart cats which can do useful things, but explanation is an entirely interesting issue. And those are very important for medical scenarios in particular, because just to make sure that the doctors are not taken by spurious correlations and the past performance to just believe the current diagnostics and so on. So that's something, we need to keep an eye on. It's going to, this technology is going to be used because there's huge amounts of advantages. It's really trying not to be just too much of a fanboy to this, and try to kind of make a, sort of have a cautionary note in the back of our heads. And that's very important, I think.
Got it. Now, Nalia, could I, oh, go ahead. Go ahead. I didn't mean to interrupt you, Geraldine. Go ahead.
No, that's okay. So I would, I also want to point out that there is a level of education I think that needs to happen for the people who are building these models. Again, I'm going to go back to this concept of also diverse teams of people who do that. From our team's perspective, when we engage and do collaborative data science with some of our grantees, we do this with the goal to educate, teach people to fish, make sure that the data scientists on the grantee side walk away with the skills, they have an understanding. And there's been cases where we've had to, we've come into projects and have had to tell people, like, you need to really sit and look at what this model is doing. It's not doing what you think it is, right? And so that is, again, it's just an awareness thing and a training thing, and I think we can get there. So those are points that are very well taken in terms of the caution.
I just want to add that it's something that, the medical community, there's been this saying that much of medicine is about what is right or wrong for white males, because that was the data on which basically people focused on mostly. And it has happened before, and it becomes, you can put it on like steroids now, because certain kinds of data is more directly available. So you wind up training your models on that. Even when COVID came along, most of the earliest, COVID is actually an extremely interesting, fast forwarded history in progress in front of our eyes. If you just go back only to March and see what people were saying about what this thing does versus what we know now, we already know, for example, we still don't know the causality, but we already know that, for example, African Americans are disproportionately affected in the way this virus affects. And these were things that we wouldn't have. It would be great if, in fact, from the beginning, as Geraldine is saying, you take into account a diverse set of data, and then you make sure that you actually training your models and testing them on them. Something as simple as checking gender of a person from their face. It's been shown last year that most commercial grade systems just fall flat on their face if you go out of white males. Beyond white males, the gender can become close to 50-50 toss-up. And so then that was a great call. And when then people like Microsoft, the companies like Microsoft, IBM, Amazon, heeded that call, they actually improved training. And now we are in much better situation. It's not at that level of problems in terms of the ability to do it for across the populations. That becomes day-to-day problem in health in particular, because there are many things that are common in humanity, but there are also enough things that are different from the different racial backgrounds and so on. And then it's very important to make sure that these things are we're checking that in the training part.
Right. Thank you. Well, Analia, I was going to ask if just from your a chatbot is part of what that's part of your system, correct? And am I correct about that? Oh, I think you're muted.
You're muted, yeah, go ahead.
There you go.
No, the chatbot is a service that WhatsApp gives to the government of Buenos Aires City.
Oh, okay.
Yes, and it was Buenos Aires City was one of the first city to prove that, and we use it for people ask about different issues in the government, and we introduced some algorithms to during the pandemic, and at the beginning of the pandemic, every people who were from Europe, because here the COVID begins when people after holidays came back to the country, and and began to call to the 911, and our telephone central collapsed. So we introduced the chatbot to people make questions, and then if those questions were similar with COVID symptoms, the medical attends this chat and decide if this person needs to be isolated in a hospital or in a hotel at the beginning of the pandemic. Then we introduce more algorithms and use for people that we know for our electronic health record that person has COVID. We send a text by telephone and invite them to interact with the chatbot to monitor the symptoms. And something similar with the close contact that the person declared in their electronic health record. And we all those informations send it to the contact tracing software.
Now I'm on mute. Thank you. Great. Appreciate that. So, you know, I guess I had a topic just to bring it back to something you had initially raised, Elena, was the worry about the potential for additional privacy and security threats when certain health services that would otherwise be transacted in person now occur over the internet. And I was curious about some best practices that you might know of or recommend, or maybe where there's a gap. Maybe that's part of what maybe we're identifying where there's a need for further work, or all of the above. But best practices that could mitigate some of these concerns, and how would you recommend that policymakers, either with a government policymaker or even with, you know, as a organization, it could just be like a large company, for example, ensure that patients can retain strong privacy and security assurances as healthcare is digitized?
Thank you. There is certainly a lot of work to be done. And I think one of the greatest solutions, and one of the most complicated as well, is to have legally enforceable rules. So we already have in Europe the General Data Protection Regulation, which some claim that it's a little bit preventive of innovation. At some point it's true, but I would say it's preventive of innovation, which doesn't serve for people. Because one of the things which must be always taken into account is what is done with that data. Because for now, many people, they do not fully realize what data means. And the data we produce, that it has value, that it has a lot of value for certain entities, and certain entities sometimes acquire this data in a quite illegal way. It can have implications both personally and collectively. The personal implication, for instance, could be that, especially for some famous people or politicians, that it can be personal bullying or some kind of cyber threats. We have seen it recently in Finland. There was a massive leak of the data of patients from the psychotherapy center. And the person who initiated the cyber attack, he started to kind of blackmail these patients because you can imagine what comes up with psychotherapy, what kind of personal data is there. So he started to threaten them that he will leak certain aspects about their private life and so on and so forth. So it's a huge gap as well, not only having the rules, but also enforcing them, building the systems which are privacy friendly by design, which respect security, IT security rules by design. It's not there yet, unfortunately, in many developments and in many countries as well. Also in very developed digitally, as Finland, we have seen that. Collective threat can be discrimination. There was already a mention, for instance, of the US example where Black community is discriminated, and there are some examples, especially from AI applications in hospitals, that the algorithm sometimes is programmed in such a way that it's discriminated by design. It can also happen anywhere else. It depends how we program these algorithms. And there is a huge need to also establish the borders, how much we would allow the technology come into our lives. So what are the new ethics? If we speak about the doctors having a Hippocratic oath and having certain norms and values which are established in practice, and they are very, very long-term, evolving with the societal needs as well, then we have to speak about digital technology having the same norms and having also legally enforceable norms, because just saying somewhere that this is ethical, this is not enough. Because for now, there are many, many ethical codes, especially about AI produced by different entities, even at the country level. But all of them are different. So if we speak about 100 ethic codes, then we speak about 100 different ethics. So how to come up with the universal ethical norms, how we approach the technology and how much we allow it in our lives, that's a huge question.
Interesting. Geraldine, if I could, I believe AI for Good has developed some recommendations that speak some of this, correct? Yeah.
Yeah, all up from a Microsoft perspective, we have a framework that for security and privacy and how we operate from an infrastructure perspective when people put data in our cloud. I do want to touch on one comment that was made around GDPR and innovation. As a software and technologist person, I was leading the Microsoft Genomics team when we were going through the prep for GDPR. It was an all hands on deck for a software company like Microsoft. Like every single product had to be touched and looked at, right? And rather than it kind of stopping innovation, I actually think it made for better products, right? Because it forces you to take a new lens to what you build and really look at every place where data is, every data flow, right? Not only in the data that's coming in that might be somebody's PHI, but where could this data leak out in logs or crash dumps and things. So I think it makes for better products, right? So I actually think it's the flip side, right? We are better because of that. And then I also want to quickly touch on privacy preserving technologies. I think there's a ton of opportunity for innovation in this area, and we need to continue to push that forward. In the U.S., we have HIPAA and HITRUST. And some of the things under HIPAA and HITRUST are almost like hitting a sledgehammer with a nail. So redaction via safe harbor is a pretty macro level way to look at this. We're doing some investment in work on privacy preserving technology called differential privacy. This is work we're doing with Harvard IQSS. It goes back about 13 years to some work done by Cynthia Dvorak out of MSR, and we're actually now doing the work, taking it beyond research, and our Azure team is working with Harvard to put this out in open source for people to use. It uses a statistical method to ensure privacy by adding statistical noise to data. So that's like one option. There's a lot of people looking at things like synthetic data generation using GANs, and so a bunch of different techniques here. I think we need to continue to push these techniques forward and invest in the research in these areas as well.
Thanks. That's very helpful. Svetlana, I'm curious just to ask it, kind of from the startup angle, how you all have tackled privacy and security. I know, and just to throw it out there, something that I know a lot of people talk about. I know it's a lot easier to talk about than to do, but is privacy by design, the idea of building in some of the built-in measures to enable for some kind of scalable risk management. Not even just for privacy and X by design, right? But what the real world perspective? I'd love to hear any of your thoughts.
Yeah, for example, here in Europe, we are forced more about privacy because we have a GDPR rule. and each application what we're doing, or for example weather application, we are forced to apply this one. But it's very interesting that we know that global rules about, for example, if children, any kid want to create any account, he need to be at least 30 years old. But we know from our children that they're creating more early, and we don't accept this one to be public and to create. For example, we have some cases in summer school where also we tested some from our application, gamification and some interesting stuff. And everyone had Facebook, everyone has Google account, everyone, but and everyone is less than 30 years old. It's important about the price, I'm pretty sure, but from perspective about the, for example, startups or company that's early stages, my opinion, it's very important, and also in innovation. And if some user want to try it and want to be involved here, I think it's need to be open these doors. But many rules like Apple Store, Google Store, they force this one, and it's really difficult to innovate in this direction. It's my personal opinion. And we really have cases about the children when they create it, because application is divided in two parts. One for the parent, and second part is for the kids. And kids, when they create a simple enter in the screen, they also want to create the account, but we can't create for them account because application will be banned in App Store and Google Store. It's simple.
Thanks. Okay, well, I did have, I don't, it doesn't look like anyone else is bringing in here. I don't want to cut anyone off, of course, but, you know, there was one other thread that I think might be worth picking up on here that I know has been raised by several people, which is it can't be overstated enough. Am I saying that right? It's a very important, angle is what I'm trying to say. Inclusivity. Accessibility. I'm really glad that a number of you have raised this so far. So, you know, what do you think? And really, kind of, this speaks more generally to, I think, a shared priority across the IGF community about bridging the digital divide, if that's the right phrasing there. I believe it is. So, what do you all think? What's the best way to bridge the digital divide that threatens to leave some folks out of the positive advances that are being made in digital health? And some of this fast forwarding is where I was describing it, which I do think is a pretty apt way of putting it.
I think it's very, very important to forget about the existence of the average consumer and to start thinking about society as a whole and about all the groups which are in this society. If we speak about, for instance, the technology developed for a particular country or region or maybe worldwide. Because what we will see if we look in the society, there are many people with very different needs and very different desires. Some are more open to use telemedicines. Others will be more willing to have their medical devices fully digitalized, connected to their doctors. Other people will want to go to the doctor because that's part of their social life. I'm coming from Eastern Europe, and I know that for my grandparents, it was part of their socializing to go to their GP and chat with that. And that's also must be respected. Then we should not forget that there are also vulnerable groups which might not have access to the right technology. Again, I'm getting back to COVID apps. For instance, in Belgium, it's not possible to download an app on an iPhone which is 3 years old, which is a little bit ridiculous. Not everyone's supposed to have the latest model of an iPhone to use the tool. So that's one part. Another part, we should never ever forget about people with some disabilities. So we need to think, if we think especially about the healthcare apps, people who have problem with eyesight, who might be having hearing problems or anything else which would prevent them from using that technology. So to really tackle that inclusivity, we need to think about the variety of people and the variety of their needs. Of course, simultaneously, we have to raise the level of digital literacy. And I also want to emphasize that it's very important simultaneously to use health literacy, not only the digital one, but in the context of healthcare. Many people somehow still don't know by the statistics where the heart is located, on the left or on the right. So how can we speak about understanding algorithm if we still don't know from where our heart is? So many things to tackle, but we need to, as a whole, it's the society as a whole should be considered.
Thank you. Anyone else? Oh, go ahead there, Nelly.
In the same sense that Selena said, yesterday's panelist Sonia Jorge said in the main session that digital inclusion is the concept where everyone can be included. This implies access to the internet, access to digital technology, but also the possibility to use it in a way that is empowering. It is important that we work to overcome these challenges as our public health users are elderly and in the public sector, middle to low incomes families. We need to find the right partner that helps us bring inexpensive networks into slums and to promote capacity building inside the community. Meanwhile, the government policy consists in implementing community networks in public spaces like subways, squares, public schools, public libraries, and working in digital education at first years of all the education programs. Thank you.
I'd love to just tag on to the concept of vulnerable populations. I also think we really need to do a better job of making sure we're accurately reporting on data in some of these areas. Some of the work that our team has done, for example, here in the US, has noticed that when we report COVID positive tests on a state-by-state basis, sometimes race data isn't included there. So how do you fix a problem if you can't understand the problem? And it makes it very difficult to be able to target interventions appropriately, right? It's a resource allocation problem, right? There's a limited pool of resources that we can allocate. We need to know where the problems are, and some of that comes from understanding and being open and honest about this from a data perspective. So I just want to raise that comment as well. And then on the accessibility front and addressing people who have accessibility needs, I really think this again goes back to the concept of designing with people and inclusive design.
Absolutely. Though I couldn't agree more with what you just said there. One thing I don't think I definitely had not asked about myself yet, but is a really important point that you just mentioned, I think, was data interoperability. How much of a challenge is that? From your different perspectives. I know, that there's private quote unquote, there's standardization efforts that are not necessarily housed by governments, for example. Like HL7 is an example of a standard setting organization trying to do this to create specifications for data fields, the fields that you would include, so that race data, for example, is always included as in as information is shared across health systems and things like that. Is that, I'm curious, Svetoslav, Nalia, Yelena, anybody, running with what Geraldine just mentioned, health data interoperability, has that presented challenges to you in practice? It's one that's talked about quite often. And, maybe what do you recommend, how it would be dealt with?
I think it's indeed a challenge. I can give you a positive example of what was done in the EU, because many countries are now introducing electronic health records, and because we move a lot from one EU country to another, And it would be useful to have, for instance, my own record when I move somewhere, or even for holidays, if I need the medical care, for instance. They are now introducing the system allowing interoperability between different systems of the country. But for this, they needed to agree on how do they encrypt the data, which standards do they use. And actually, the HL7 is the standard which is used for this infrastructure in the EU. But of course, it's only one fraction of data when we speak about electronic health record, but there will be others. And how do we agree on interoperability and the standard used for the others? Who knows? And another huge problem which comes up a lot, especially in the area of less structured data, is quality of that data. So there is now a very popular concept in the EU to use the real world data to as a complementary source for any kind of decision making. Also, it's very popular to speak about it in the context, for instance, of new medicines development. There will be a lot of initiatives in Europe to apply that data as a complementary source for clinical trials. But then the very big challenge is how do we ensure that this data is of good quality? Because if someone picks up, I don't know, someone's comment on Twitter about their reaction to a medicine, I turned red like a lobster. What does it actually mean? Is it a good quality? Is it complementary source? Did that patient eat something else which caused the redness on his face? So there are many questions to answer and also to agree on how do we approach that. And it's never easy at the EU, once again, because there are many healthcare systems and many national rules on how it's approached, especially in health research.
Rao, I see you're unmuted. Do you
No, I did.
Oh, I thought you were trying to talk. No worries at all. Anyone else? Anyone I'm curious about the data interoperability. I mean,
I think
go ahead,
interoperability is a challenge, and it's always been a challenge, right? And I think there's some great work happening in the HL7 community, for example, to enable that. There's a subtlety, though, in what I was talking about at some of the challenge. The challenge isn't always technology. Sometimes the challenge is policy, right? Because by policy, people may not report out certain sets of information, and policy is a little harder thing, right? And also just, there's many cases and examples in COVID where there's a policy component to this concept of data, of data. For example, understanding where people are in terms of their state, that like lockdown or not lockdown, where are they at in that kind of spectrum? That's information that's really very, very hard to gather. There's no consistent way to capture that and represent it. Most people don't report out on it, but it's really super important information if you want to track, for example, progression of disease and understand what has been most efficient at curbing the spread. So there's a policy component to it. It's not all technology.
I share at the chat some links. Sorry, are in Spanish, of course, because are at the national level. They have been working and published a lot of interoperability standards for all the problems. We are a federal country, so each province can decide if adapt their system to this interoperability standard. In the Buenos Aires city, we did it, and our health electronic record accomplished with these objectives. So we technically can exchange information between the public or the public sector or another province that accomplish the same objectives. So we need to define the politics to do that, because at the national level, cities have an application that, that they can put if they want to share or not their health information between different provinces or different sectors, health sectors. But the problem is that each government decides to share that information between different provinces. And we understand that it's useful for better quality of health and better decision making, but generally policymakers are afraid that the other province use it for political issues against one to the other. So we are discussing now if the information is the patient is the owner of the information, we should allow that exchange, but it's not happening yet.
Understood. Svetoslav, I saw you unmuted earlier, and did you have anything? I don't want to skip over.
I agree with all of that they said, and I think the main point is the policy and the rules of each country. For example, here in Europe, it's really big advance that Europe has so many countries that it is from the same umbrella. But in the same time, each country has each rule of each rules of himself about the policies and so on. And when you want to extend for new market, you need to study first the policies. Only after you can go with technology, go there about the health. Yes, I totally agree with Garlin that it's very important the policy to be united or simplified in direction about innovation.
Great. Well, I know that I had maybe one more, just looking, do not see any audience questions yet here, but we are closing on the end of our session here. And there was one, I can kind of ask a two-pronged question that you can answer both questions if you'd like, or just one of the two maybe. One is that the IGF as an org has told us that they're interested in what in what voluntary commitment or commitments us as the session participants are undertaking or will undertake during the next year to address some of the challenges that we've raised, and so that's one. The other maybe part of this is if and because I do think that point about policy is very important. If there was a way, if there was one policy that you could change that would responsibly advance digital health uptake and improve outcomes for patients, what would it be? So maybe these are linked. These were two questions I wanted to make sure to ask and wanted to try to fit them in here. So please, anyone, go ahead.
Okay, I choose the promoting trust and security in digital environment, because it was the most important issue discussed during the telehealth services. So we need to work on that. And we are at the beginning on biometrics identifications and personal health portals at the public health sector for better security for and privacy for patients and healthcare workers.
I'll go next. I want to echo that, because I think that's really the overarching umbrella. When I look at some of the AI things, you can't be successful with this without an umbrella for trust and security and privacy, right? And so that would be our commitment. And then I also want to put in the, if I was queen for a day, what would I hope? I would hope that we can bring broadband to all, quite frankly, to enable people who may otherwise be marginalized, and to recognize that what we learned in this pandemic, that that access, internet access, broadband access, is a social determinant of health. And it affects the way we work. It affects the way our children learn. It affects our healthcare. It affects the way we play. And we're not out of the weeds yet from a pandemic standpoint, right? Even though there's vaccines in phase 3 trials, it is likely going to be a long period of transition until we get back to normal. And so, just understanding that we have to bring everybody along in this journey, and there is an element to that is dependent on access, equal access.
Yeah, I agree with them. I agree about the umbrella. Also, I hope that the next step, when COVID will be end, that everyone will start to invest in the healthcare, because we see that each country is not ready about the healthcare, and we need to be more adult in the healthcare. And this is important steps, in my opinion, after the COVID crisis.
So I tend to be a realist, and I'm obviously not on the ground like many of the co-panelists are. It's clear that many advances in medical technologies would be driven with some profit motive. The great Pfizer COVID vaccine requires minus 94 degrees Fahrenheit maintenance. Tell me exactly where outside of the richest places and richest counties can that be used. But having said that, I think digital connected health, I see it as like a great positive force in reducing some of the inequities. If I were to develop, let's say, a diabetic retinopathy, healthcare system, it'd be so much easier to actually transport it. In fact, one of the interesting things is that Google did this study in Thailand to see whether or not, how the super accurate system they developed, how is it working on the ground. And they learned a lot of interesting lessons, not the obvious ones. In particular, they do have broadband, but they actually wound up saying the real use on the ground actually changes the kind of accurate images they might be expecting, and they had to go back to the drawing board. I see that as a huge positive thing, because I didn't really see that sort of, in the old days, without connected health, without digital health, you would be sort of, private companies don't have that much of an interest in making sure that what they're doing would be helping the countries that don't have, the sort of resources. One nice thing is the cell phone penetration is extremely high, even in some of the poorest countries in the world. And, there is a certain level of healthcare support that will be brought with respect to this sort of connected health because of those kinds of things. And there's an interesting article I read somewhere about this guy sitting in US is helping his folks in Nigeria or somewhere, where they basically use this cell phone, very bad pictures, but that's still enough to give them useful diagnostic help that they never had before. So I think of this overall, we talked about what all the worries we have, but it's also a question of, I think this is probably helping very much the UN Sustainable Development Goals, in the sense that it actually brings, what is happening in the US and the richest countries much faster to be of use to countries which don't have that kind of resources. So yeah, my cynic part of me is actually less cynical on the connected health side.
And I think my commitment for next year will be directly linked with what is happening in the EU and what is planned to be done next year. And among these things is creation of regulatory framework for artificial intelligence. And also, of course, I will pay specific attention to how AI will be applied to healthcare. And another huge topic is, of course, uses of secondary health data in research and for other purposes. We will be also working on the legal framework for this. And my secret desire of what I would what I would change is I would probably create a magic law which would ensure that companies who create AI and other technologies which all will be using in our lives to be transparent. So it's clear for all the users how this algorithm is functioning, why it is made this way, where their data is going. So that's the only way how we can create trust from the user side, is only by communicating transparently to everyone. So I would create a magic stick to ensure transparency.
Well, great. Thank you all. I know that we've run just a bit over, but this really has been this is a really wonderful group, and we appreciate all of you joining, and for people watching this in the future, because there will be a recording of this that the IGF will post. But this is a really rewarding discussion. I think lots of interesting discussion about all the many different angles here under that umbrella of the pandemic, and how digital health is assisting and the challenges that are faced. I, like you, Rao, remain an optimist. I do think that while there are many challenges, indeed, we are already seeing great evidence that the uptake of digital health tools and new advances, including in AI, do improve patient outcomes and reduce systemic costs. And you know, if we can just deploy it responsibly, that's the word I always kind of run to, is the responsible deployment that keeps in mind many of the concerns that we've articulated here and elaborated on. The future is very bright. So I guess I would stop there and say the future is very bright. And again, thank you all very much for your participation in this IGF session.
Thank you.
Thank you for inviting us.
Thank you.
Thank you.
Bye.
Thank you.
Bye all.
Bye, guys.
Have a nice day. Bye-bye.